in listen-only mode.
Hello, and welcome to the Public Health Report's Meet the Author webinar. My name is Mary Beth Bigley, and I'm the former editor of Public Health Reports. In my current position, I'm the director of the Division of Nursing in the Bureau of Health Professions at HRSA. The Meet the Author webinar series is sponsored by Public Health Reports, the official journal of the U.S. Public Health Service and the Office of the Surgeon General. This webinar is presented to stimulate discussion around current topics in public health. Today's webcast, Nursing in 3D, Workforce Diversity, Health Disparities, and Social Determinants of Health, will highlight relevant work currently underway in the federal government and public sectors and presents various pathways and partnerships that can help improve health equity. This webinar features experts in the nursing workforce diversity, healthcare quality and access, health disparities, and determinants of health. They will be discussing the academic and healthcare system factors, as well as social, economic, and environmental determinants that influence the health workforce diversity and health equity. I'm delighted to introduce the speakers for today. The first speaker, Dr. Shrenda Williams, is the Chief of Nursing Practice and Workforce Development in the Bureau of Health Professions here at HRSA. As Branch Chief, Dr. Williams oversees the Division of Nursing, Nurses Education, Quality Retention, as well as Nurse Workforce Diversity Portfolio. She is a family nurse practitioner and social epidemiologist. She is also the National Institute of Minority Health and Health Disparities Research Scholar. The second speaker, Mr. William Freeman, is Staff Service Fellow at the Center of Delivery Organization and Markets at the Agency for Healthcare Research and Quality. While at AHRQ, he supports the annual National Healthcare Quality and Diversities reports, as well as leads projects in healthcare quality and patient safety measurement. Third speaker is Dr. Paula Braveman. She is a professor of family and community medicine and the director of the Center for Social Disparities and Health at the University of California in San Francisco. For more than 25 years, Dr. Braveman has studied and published extensively on health equity and the social determinants of health, and has actively engaged in bringing attention to these issues in the United States and internationally. The final speaker is Dr. Janice Phillips, who is the Director of Government and Regulatory Affairs at CGFNS International. Dr. Phillips is an experienced clinician and researcher, educator, and public policy advocate in the healthcare arena. And in 2010 and 2011 was a Robert Wood Johnson Foundation Health Policy Fellow who worked with Senator John Rockefeller in West Virginia. With diversity spanning oncology, public health, women's health, health disparities, and research administration, she has demonstrated her ability to build and maintain strategic relationships and partnerships among academic institutions and scientific investigation and healthcare and advocacy groups. On behalf of the Division of Nursing here at HRSA and the Office of the Surgeon General, I'd like to thank the speakers for their dedication and hard work in preparation for the supplement. In a few minutes, I'm going to turn the webinar over to the first speaker, but here's the issues. This webinar will be archived on the Public Health Report's website for future viewing. If you are interested in seeking one credit for accreditation in public health continuing education practice, you'll be given a pass at the conclusion of this webinar. Following the presentations, there will be a question-and-answer session. To ask us questions during the webinar, question into the chat box, which is in the which you can open up by clicking the small white arrow in the upper right corner of your screen. It is now my pleasure to turn the program over to the first speaker, the branch chief for the Division of Nursing here at HRSA, Dr. Shrenda Williams. Let us begin our presentations.
Hi, this is Shanita Williams. Welcome, everyone. The Division of Nursing sits in the Bureau of Health Professions at HRSA, and the Division of Nursing is the lead or the key federal focal point to ensure that there is an adequate supply and distribution of qualified nurses to meet the health needs of the nation. This includes having an adequate supply of diverse nurses that reflect not only the U.S. population, but also the populations in which they serve. And so the primary lever in which the Division of Nursing implements its diversity agendas through its Nursing Workforce Diversity Program, or the NWD program. So the NWD program was legislatively mandated under Title VIII in 1989 by the Public Health Service Act. And the NWD program since that time has awarded over $160 million in institutional grants. We looked at did an evaluation of our NWD program back in 2012, and what we realized is that we have not seen a substantial change in the diversity targets despite these investments. And so what we decided to do is that we need to take a new direction. We realized that the nursing community alone cannot address not only diversity, but we can't even begin to address health disparities and health equity in isolation. And so we decided that if we were serious about increasing diversity, if we were serious about disparities and health equity, that we would have to engage in a collective effort across all disciplines and all sectors, including those sectors and disciplines outside of healthcare. And so what we decided that we needed to do then was to add to our portfolio of investments cross-disciplinary resources that addresses not only diversity in isolation, but linking that to health disparities and health equity. And so as part of that process, we did some real hard thinking on this, and we developed a simple linear conceptual model. And we call that model the transformation from health disparities to health equity. And simply, the model just, within the context of the social determinants of health, we feel that if we can increase diversity, that would lead to an increase in quality and access to services. That would then lead to decreases in health disparities, which are necessary in order to achieve health equity. And that's a simplified version of that model. And so we developed that model, and then we convened a summit in 2012. And next slide. And the summit was, the goal of that summit was to provide our nursing stakeholders and our grantee communities with the intellectual and conceptual tools that are necessary to apply the complexity of social determinants to advance our health, our agenda, which includes the nursing workforce diversity and health equity agenda. So as a part of that process of convening that summit, we also wanted to avoid the, okay, that was a great meeting, so what happens next phenomenon. So when we reached out to invite various speakers, next slide please, and we invited speakers in various fields. We invited experts not only in nursing but in epidemiology. We reached out to medicine experts, those in public health, experts in the fields of health disparities and health equity, both inside the federal government and outside of the federal government. And when we asked or invited those speakers to participate in the summit, we also asked them to commit to writing a manuscript. And that manuscript will include their ideas of how to move forward with a diversity to health equity agenda. And we also asked them specifically to address one or more of the constructs or elements within the conceptual model that we developed to frame the meeting. And so today you have access to a few of those authors who agreed to contribute papers and to also, to add to the supplement their ideas for moving forward. And so we invite you to not only ask these exceptional authors specific questions, but we also invite you to read all of the papers and the supplement that was designed around this topic. So our author, who I will introduce, is Ernie Moy. And Ernie Moy was the primary author, but Bill Freeman will be presenting. He is the secondary author on the paper. And Bill is an excellent representative of our federal agency, the U.S. Agency for Healthcare Research and Quality. So Bill, you're up next.
All right, great. Thank you so much. So this is Bill Freeman, and just a full disclosure before we get started, I actually work in a different center now. I work in public reporting at AHRQ, but I'll only point that out so that if anyone has any questions, do not email me. I'm, of course, just kidding. You can email me, and I can forward it on to Ernie Moy, or you can just email him directly. So I do want to start off with just mentioning, so I was on the National Healthcare Quality and Disparities Reports project for 5 years, and that's 5 cycles, so I definitely know them inside and out. And I want to bring that up. I want to tell you guys a little bit about that project because I'm going to be showing some data here in a minute about that. So the National Healthcare Quality and Disparities Report are 2 annual reports, and they provide a comprehensive ear to the ground to show what the healthcare quality is in the nation. And they're made up of over 200 different measures, healthcare quality measures, and it's framed around the Institute of Medicine's healthcare quality framework. So there's 8 dimensions of care, and then 2 different domains. And so just to give you guys a heads up, that's where some of the data is coming from. Next slide. And so I'm sorry, go back to the agenda. So I just want to go through what I'll be presenting first. As a pre-doctoral student or a doctoral student, I'm very aware of the fact that we need to show whether or not the data is showing there is a problem, so I'll discuss that. And then I'm going to present the HHS action plan to reduce racial and ethnic health disparities. Then I'm going to present the conceptual framework that Dr. Moy and I presented in our paper, and then go to what we really think is a major pathway for equity, which is improving the workforce diversity. And then the way that the National Healthcare Disparities Report tracks workforce diversity and several HHS and ARC efforts to improve diversity, and then round out the discussion with implications, some action items, and my prediction for the future. All right, next slide. All right, so first, is there a problem? So this first graphic is from the Disparities Report, and it's updated every year. This one presents the number of measures that are either getting better, staying the same, or getting worse compared to the reference group, in this case, whites or non-Hispanic whites. So working from left to right, we have the first one. I actually converted these over to percentages, so it's a little bit easier to understand. So looking at blacks versus whites, we have, of the 200 measures that we analyzed, 39% were worse and 15% were better. Looking at Asians versus whites, about 25% were worse and 26% were better, so that's actually about even. But then looking at American Indians and Alaska Natives, where we had 120 measures we analyzed, 33% were worse and only 9% were better compared to whites. Looking at Hispanics versus whites, we had 190 measures, 42% which were worse and only 21% that were better. And then most drastically, the high versus low income, where out of 117 measures, 54% of those were worse and only 5% were better. And of course, what we would expect if there was no sign of disparities would be that there would be something more akin to the Asian versus white, where there's an equal amount that were better or worse, but we might expect it to be smaller, maybe 10%. Next slide. All right, and this next one is also what the Disparities Report does is track trends over time. So what we're looking at here are whether or not disparities are improving, not changing, or worsening over time. And there's 2 things I want to point out here. First, looking at comparing those that are improving compared to those that are worsening, there's actually more that are improving compared to worsening, so that's good. But then the second thing is, obviously, that there's a huge amount of stagnation. Most of these are not changing. That really overshadows the good that's being shown here. And so the data is really showing us that, yes, healthcare disparities exist, and they're persistent over time. Next slide. All right, this is the goals for the HHS Action Plan to reduce racial and ethnic health disparities. I'm not going to go through each of these, but just to the two that are kind of connected to what we're talking about here today, which is to transform healthcare, and one strategy that we're doing to do that is to reduce disparities in healthcare quality. Looking at goal number 2, strengthen the health and human services infrastructure and workforce. So an example of one of the strategies we're doing is to increase the ability of all health professions and the healthcare system to identify and address racial and ethnic health disparities. And I want to point out that whereas in the past we may have had federal action plans to tackle different public health initiatives, they may or may not have had teeth, but this one definitely has some teeth in that we've really, across the department, started to align our initiatives, our research grants, our contracts, our special programs, and we're creating new tools and partnerships to really try to tackle disparities and strive towards these goals. Next slide. All right, so this is the conceptual framework that we present in our paper, and so starting from the bottom left, working clockwise, we're going to start with social determinants of health, and so these could be family and community assets, and of course financial resources and the knowledge resources. And these are really where we start to see an effect on access to healthcare, and that's where healthcare disparities really start. Is if a family or a person has limited resources, that really starts to limit their access to care. Looking at the healthcare disparities at the top, and this can be this is more what's happening in the healthcare setting. This can be caused by patient-provider interaction issues, so miscommunications, misunderstandings, as well as just plain provider bias. And so that's where we start to see real impacts that can lead to health issues. So this starts to affect, it creates a deviation from the optimal path of treatment, and so that relationship C, the treatment adherence, that's where healthcare disparities really starts to make its impact on health disparities itself, which is on the bottom right. And so this is these are disparities in mortality, morbidity, quality of life, and so and then those can then influence back to social determinants of health. So the inability to work because of health issues, that definitely can impact those social determinants of health, those financial resources, for example. And then social determinants of health can then go back to health disparities. So the education level and the decisions about exercise and diet and things like that can definitely impact health disparities. But really at the center of this is workforce diversity, we feel, and that workforce diversity can really impact a number of these relationships. Next slide. All right, and so we see this as a major pathway to equity is to improve workforce diversity. So you might be asking, well, how can increase in workforce diversity reduce health and healthcare disparities? So for one, it can lead to better patient and provider communication, so better adherence to optimal treatment, and improving equity in health outcomes and quality of life. And there's a number of examples of tools that ARC has developed to try to help improve both health literacy and patient-provider communication. So the CAPS cultural competency models, the class standards, and a number of others. But then also workforce diversity, looking at the second bullet, can help improve equity through example. So those that increased diverse workforce can then provide examples to colleagues, leading to cross-cultural learning, and can lead to better understanding, reduced bias, and ultimately improved patient care. Then looking at the third bullet, so improving workforce diversity can also directly affect the social determinants of health, higher wages, leading to improved access to care. They can that increasingly diverse workforce can then be resources to their family, to their friends, to the community. And just to mention a couple of AHRQ and HHS efforts to improve workforce diversity, there are a number of K awards. These are grants for minority students that ARC provides. Also, we participate in the National Research Service Award, and there's several other programs that ARC participates in, as well as the department, to try and improve workforce diversity. Next slide. Okay, and so this is where go back one slide, thanks. So this is a graph also that's produced annually. Oh no, my computer went to sleep. Okay. So what we're presenting here is the composition of the U.S. population compared to a particular healthcare position. And so here, because this is nursing in 3D, we're presenting nursing positions. And this actually is very appropriate because it shows something interesting. But just so you know, in the past we've presented on physicians and surgeons, on physical therapists, dentists. But at any rate, so what we do here is we pair information from the American Community Survey against the matrix for the U.S. population. And so looking from left to right, we have the more advanced nursing positions on the left, and then these are often more higher paid positions as well, and then going to lower skilled towards the right. And so what we see is, compared to the U.S. population, there's an overrepresentation of whites and Asians in those more advanced and typically higher paying positions. Whereas on the looking at nursing age, for example, there's an overrepresentation for blacks, and these are typically lower paid. So if we can work to create more equity there in the workforce, then we may see improvements in social determinants of health, as well as in other things I mentioned. Next slide. All right, so what are the implications for health and healthcare? So first, I want to just talk about the community health workers' role. So there's interventions that are delivered by community health workers that improve the knowledge about the importance of health screenings, prevention, and self-management to underserved populations. And besides just improving health outcomes, this can result in more appropriate utilization of health services, so reducing the burden on resources. Looking at the action items, so what everyone could do is just think about ways that you can help blunt healthcare disparities from your vantage point. So whether you're a researcher, a public health professional, a provider, I've outlined a number of interactions and relationships from which healthcare disparities and poor health outcomes can be mitigated. So think about what you can do and help us create change. And then lastly, just my predictions. So growing diversity for a population is inevitable. I'm sure you all know the numbers and the statistics of change, but cross-cultural understanding and competence is not a given. So the efforts already underway to improve both workforce diversity as well as mitigate or weaken health disparities will help us see change, and hopefully we'll start to see the scale tip in the right direction. We can really start to witness health equity. And so with that, that's actually the end of my presentation. So I'll turn it over to Dr. Paula Braveman, who's a professor at UC San Francisco at the School of Medicine in the Department of Family and Community Medicine in the Center of Social Disparities in Health. Thanks very much.
Hello, it's a real pleasure to be participating in this discussion. I was asked to discuss the concepts of health disparities, health equity, and social determinants of health, which are being mentioned frequently, to try to put us all on the same page. Next slide, please. Okay. So what do we mean by health disparities? If you look in a dictionary, the dictionary will generally define disparity simply as a difference without restricting it to a particular kind of difference. But I want to ask you if you regard any of the following health differences as health disparities. What about more fractures among skiers? What about the fact that the elderly generally have worse health than non-elderly adults? How about what if you learned that one group of wealthy people in one neighborhood had worse health than another group of wealthy people in another neighborhood? Well, many official definitions of health disparities refer only to differences between unspecified groups. And on that definition, all of these three examples would qualify as health disparities. So I ask you, would you recommend that resources to address health disparities should be directed toward those differences? I doubt it, and I hope not. Margaret Whitehead eloquently defined health inequalities, which is a term used outside the U.S., as differences in health that are unfair, avoidable, and unjust. And this has been inspiring and helpful in many situations. But the problem is that ideas of what is just, what's fair, and even ideas of what's avoidable can vary tremendously. So while we can use the Whitehead definition in many settings, we also need a definition that is more rigorous and can protect resources for the intended purpose. To do this, the definition must be able to guide measurement, because without measurement, there's no accountability. Next slide, please. I believe the human rights principles give us a basis here. They cover not only civil and political rights, such as freedom of speech, but also economic and social rights, such as the right to health, the right to a standard of living that is adequate for health, and the right to education, and many other rights. Human rights agreements obligate governments to progressively remove barriers to achieving all rights for all people, but particularly for those who face the most obstacles. The human rights principle of non-discrimination and equality prohibits actions with either the intent or the effect of discrimination, and it requires affirmative action to correct the effects of past discrimination. Next slide, please. Human rights agreements specify social groups who warrant special protection, including racial, ethnic, and socioeconomic groups, LGBT groups, and the disabled, and others. The implicit criterion is the group's historical experience of discrimination or exclusion, and we can verify which groups have experienced discrimination, for example, based on documentation of slavery, genocide, denial of voting rights, or others. Clear criteria are needed because relatively privileged groups may try to make a claim on resources for health equity. Next slide, please. Based on human rights principles, Healthy People 2020 defines health disparities and health equity in a way that I believe gives us the guidance we need. Health disparities are health differences closely linked with social disadvantage. The disparities must be linked with disadvantage, but we do not need to establish the causes. They adversely affect groups that have systematically experienced greater obstacles to health based on discrimination or exclusion. Health disparities are the metric that we use to assess our progress toward health equity. Equity means justice. It's the principle underlying our commitment to eliminate health disparities. Next slide, please. So what's the link between health disparities and health equity on the one hand and the social determinants of health? They are linked because health equity calls for justice in all of the factors that influence health, not just in health care. This is consistent with human rights principles, and in addition, a growing body of science has highlighted how crucial the non-medical influences on health are, influences such as income, education, housing, and transportation, for example. So next slide, please. To illustrate how important the social determinants of health can be, this slide shows how the percentage of children who are not in very good or excellent health varies with their parents' incomes. The far left bar represents children in poor families, and income rises as you go from left to right. You can see the dramatic pattern of children's health improving as parents' income rises. The story is similar when we look at education. I could show you scores of graphics like this on different health outcomes across all age groups, and most would reveal a pattern of health improving as income or education levels rise. You can find this graphic and many more graphics and other materials on the website of the Robert Wood Johnson Foundation. If you look there for the Commission to Build a Healthier America, which recently and in 2009 issued recommendations regarding the social determinants of health. These graphics don't prove that income or education caused the ill health, but they add to substantial evidence from other research pointing to the powerful roles of money and education in shaping health. Next slide, please. This slide shows the percentage of adults with poor or fair health according to their educational level, this time within several racial or ethnic groups. I show you this to make the point that health disparities by income and education are not explained by racial or ethnic group. Both racial and socioeconomic disparities in health are important. Next slide, please. This slide lists some of the many ways in which income could influence health that are backed up by literature. Here and in all of my slides, I am not claiming that everyone agrees, but that there is a credible scientific literature supporting all the links that I'm discussing. Our options for housing, neighborhood conditions, nutrition, exercise, and services such as childcare and transportation are powerfully shaped by our economic resources. And lack of money generally means more stress, the stress of trying to cope with daily challenges without having adequate resources. Next slide, please. I just said that one's income can affect where one lives. Neighborhoods could shape health in many ways, for example, through access to safe places to exercise, to healthy food, but also in more subtle ways. For example, by influencing the social networks, role models, and peer pressure to which children are exposed. And the quality of schools often goes along with overall neighborhood quality. This can have strong effects by influencing, can have strong health effects by influencing a child's prospects for a good education, which then shapes their job prospects, which in turn shapes their income prospects, and the cycle begins again and goes across generations. Next slide, please. The literature indicates, next slide, please. Can we, okay, thank you. The literature indicates that education could influence health in diverse ways. This shows 3 different pathways that are supported by credible current knowledge. The top one is the most familiar to healthcare providers, how education increases knowledge, literacy, and coping skills, which then improve behaviors. But other pathways also are important. For example, the middle set of pathways illustrates how education shapes our work opportunities, which shapes income, which in turn can influence our health and our children's health through pathways noted earlier, as well as others. Next slide, please. Considerable evidence shows us that social conditions experienced in very early childhood not only shape health in childhood, but they're very strong determinants of adult health. Chronic stress in early childhood may lead to physiologic changes that manifest decades later as chronic disease and premature mortality. Next slide, please. Racial discrimination is thought to be another very important social determinant of health. It operates in different ways. For example, the legacy of racial discrimination, which shamefully was actually legal just several decades ago, that legacy is often called structural racism. And racial residential segregation is perhaps the best example of structural racism. Structural racism can damage people's health even when there is no longer conscious intent to discriminate, because it tracks people according to race into different socioeconomic opportunities. In addition, a range of experiences related to racial discrimination, including very subtle as well as overt experiences, also could affect health more directly for people at every socioeconomic level by causing chronic stress, which can contribute to worse health behaviors, but also may damage health more directly, for example, through neuroendocrine and immune mechanisms. Next slide, please. This slide also was developed for the Robert Wood Johnson Commission to Build a Healthier America. Its purpose is to illustrate that when we think of modifiable influences on health, we cannot restrict our focus to medical care or even to behaviors. We need to address the powerful factors that can determine who gets medical care, that shape our health behaviors, and that can influence health in other ways, for example, through stress. Our behaviors are influenced by the conditions in which we live, learn, work, and play, the middle arch on this graphic. And in turn, we need to consider the outer arch, the factors that determine who lives and works in healthy conditions and who does not. These are the underlying or structural determinants of health in the form of the social policies that shape income, education, and racial inequality. All of these are profoundly important determinants of health and of health equity. There are so many ways in which nurses and other healthcare professionals can be a powerful force for change to address these crucial determinants of health, moving us toward greater health equity. Thank you. And now I'd like to introduce Dr. Janice Phillips, Director of Government and Regulatory Affairs at CGFNS International.
Thank you. I'm very pleased to be able to join you this afternoon, and I will be discussing the importance of increasing diversity in nursing, and I'm going to highlight some key challenges in documenting the contribution. What are minority nurses actually contributing towards eliminating health disparities? And I think this is a need for a critical assessment of these and other issues if we are going to move toward achieving health equity. Next slide, please. So why diversity? Why diversity in nursing? Why do we need a diverse workforce? Well, for one, we know that there will be great shifts in our nation's demographics. For the first time in 2043, the U.S. population will become a majority and minority population, with more minorities being represented in our overall statistics. We also know from data that minorities remain underrepresented in nursing. For example, if you look at findings from the 2013 survey, which was conducted by the National Council of State Boards of Nursing and the Forum of State Nursing Workforce Centers, you will find that nurses from minority backgrounds constitute about 19% of the overall RN workforce. So if you look at the overall RN, registered nurse workforce, you'll find that 83% are white, 6% are African American, 6% Asian, 3% Hispanic, 1% Indian, Alaska Natives, 1% Hawaiian Pacific Islanders, and the other 1% other categories. So as you can see from these figures, our current composition of minorities in nursing do not represent the overall minority populations that we have today, or are they in sync with projected increases in minority populations of tomorrow. We also know that there's ample data that suggests that minority nurses and minority workforce individuals play a significant role in terms of addressing health disparities. And you've heard that from some of our previous speakers already on this panel today. If you look throughout this particular supplement, you'll find other benefits of having a diverse workforce, such as increased access to care and increased access to quality care, increased patient-provider relationships. Minorities bring broader range of perspectives when it comes to providing care and conducting research. And we also know from my own experience that minorities have a very strong sense of community and a responsibility for improving the health and well-being of those that they serve. This slide, can you go back to the previous slide, please? This slide here just speaks to race and Hispanic origin comparing 2012 and 2060. So we know from just looking at this snapshot that black populations will increase from 13 to 15%, the Asian population from 5.1 to 8.2%. Hispanics will more than double by the year 2060. In fact, about 1 in 3 U.S. residents today are Hispanics, and that's going to increase even more so in the years to come. And non-white Hispanic populations are projected to slowly decrease by 2060. Next slide, please. So one of the unanswered questions that we have, though, what are the actual contributions of minority nurses in terms of eliminating health disparities and ultimately achieving health equity? So we've heard about the underrepresentation of minorities in nursing. We've heard about the shifts in demographics. We've heard about some of the potential benefits of minorities in terms of addressing health disparities. But what we don't know, what are the actual contributions of minority nurses in terms of eliminating these health disparities? Other issues that need to be addressed: how will increasing the actual numbers of minority nurses with advanced degrees aid in achieving health equity? And where are our minority nurse leaders positioned? Of course, we see them in some positions on the government level. We see minority nurse leaders in academia and other situations and scenarios, but we really don't have a really good feel for where they are and what their actual roles are. Next slide, please. I bring to your attention this article that was published in the year 2000, Minority Nurses in Leadership Positions, A Call for Action. And this author, Smelding, just brought it to our attention that we really don't have a good idea of where our nursing leaders are, particularly those that are minority nurses. And I believe, and I'd like to suggest, that perhaps we need to revisit this call to action and find out exactly what positions are minority nurses holding and trying to link those positions with their actual roles, but also with their actual contributions toward eliminating health disparities. Next slide, please. I'd also like to offer a few more suggestions in terms of strengthening minority contributions to eliminating health disparities and ultimately achieving health equity. Perhaps we need to integrate and establish stronger linkages, linking our social determinants of health throughout all levels of our nursing education, beginning at the undergraduate level. Not only just for minority nurses, but for all nurses, really making those connections between everyday issues regarding where people live, where they work, where they play, and what does that mean in terms of contributing to their health disparities. I also would like to offer the need to support specific training in health equity and disparities for all levels of nursing, including those that are prepared at the advanced degree level. Next slide, please. Some additional suggestions include creating stronger metrics that assess minority nurses' contributions. So we need to better document what are we actually measuring. Are we measuring the actual impact? What are our definitions? What are our metrics? Are we looking to measure how well we are promoting the awareness in terms of health disparities, or are we measuring actual actions on the part of minority nurses in terms of helping to improve the health and well-being of various diverse communities? Creating a national repository to showcase the efforts would also be very important. And then I don't want to use this as a last marker here, but very, very important is the need to strengthen our affiliations and our work with ethnic minority organizations to help collect data on leadership positions and related activities. We have a large number of minority nurse organizations, and perhaps strengthening our coalitions with them and working with them to identify where their members are actually working and what roles they are assuming and what are their activities in terms of reducing health disparities. Next slide, please. I have this slide to just illustrate an exemplar at Duke University School of Nursing. They've recently received a HRSA Diversity Grant with an emphasis on integrating the social determinants of health into the nursing curriculum. Now, I know that Duke has a long and established history of addressing health disparity topics and creating minority nurse leaders, but now they're expanding their portfolio by helping students to understand the social determinants of health. And so I would suggest that perhaps we need more activity along this arena in terms of making sure that our students are well educated and better prepared to assume leadership roles in this area. Next slide, please. This slide here just highlights a few other resources I'd like to bring to your attention. An initiative by the American Association of Colleges of Nursing in concert with the Robert Wood Johnson Foundation. It's called the DAN Project, Doctoral Advancement in Nursing. And this project is designed to enhance the number of minority nurses who are actually completing their PhD and DNP degrees in nursing. And we believe that when we increase the number of those nurses prepared at an advanced degree level, they are better able to assume greater leadership roles and to deal with the increased complexity of care. Right now, if you look at the number of nurses who have their doctoral degrees, only about 27.7% of minorities have a research-focused doctoral degree. And so we need to improve those numbers as well. And then this last bullet point points us to some of those resources to HRSA. As you have heard, that the Bureau of Health Professions has a number of diversity initiatives aimed at improving diversity in the nursing workforce. Next slide, please. And so just to summarize, why diversity in nursing? Well, we have increasing shifts in demographics. We know that minorities are underrepresented in nursing. We have ample documentation that there are some benefits of having a diverse workforce. But in moving forward, we need better means and better measures of actually documenting and quantifying the contributions of minority nurses in decreasing health disparities and ultimately achieving health equity. So thank you very much.
Thank you to our distinguished presenters. We will now have time to take questions from our audience. You may type your question for any of the authors into the chat or question box in the right-hand corner of the screen. You will open the box by pressing the 2 arrows. Before I start the question and answer period, a reminder that anyone seeking 1 recertification credit for their certification in public health, you will need a password for the credit. The password for this webinar is nurse3d. Please go to the PHR website to connect to the appropriate link. And now we will take our first question. This is posed to Dr. Williams. What can health professionals do to get involved in moving the needle on health equity? Dr. Williams?
Thank you. That's an excellent question, and it's one that we constantly have to strive to address. What we first often say is that we cannot place the burden on racial and ethnic minority providers take the burden and responsibility of the care for our racial ethnic minorities and our other disadvantaged populations solely on the shoulders of our racial and ethnic minority providers. That's the first caveat. But to address the question more specifically, we have data to show that racial concordance, cultural concordance, language concordance, all have been linked to improving quality outcomes. So when it's there, it does make a difference. So for example, we know if there's racial concordance that racial ethnic minorities are more likely to serve in underserved communities. We have good data to show that there's a greater trust in the healthcare system by those who are seeking care when there is diverse representation in the providers. We also know that there's more effective communication, whether it's regarding language or communication, establishing a foundation of trust, and that there's greater advocacy as well. So those points have been validated in the literature, and we need to emphasize that, and that's a part of our, we take that knowledge going forward as part of the rationale for diversifying the workforce. So I think that may address the question.
Thank you, Dr. Williams. The next question is posed to Mr. Freeman. What knowledge gaps can public health and health services research fill to help reduce health care disparities?
Okay, thanks. That's a great question. I'm glad I could mention this. So actually, I just want to mention that there's a evidence-based practice center report out called Quality Improvement Interventions to Address Health Disparities. And this really answers the question. So it's probably a whole other presentation to talk about what the research is out there and what the gaps are. But if you take a look at this EPC report, it really highlights that there are a large number of interventions that have been identified, but that there's a few amount that are actually effective at reducing health and healthcare disparities. And so, so looking at what is out there and then what some of the success stories are, you can really start to see where additional research can be conducted that can help improve in those areas and really start to highlight effective interventions that really make a difference. So I would like to turn your, and this is a recent report. It came out, I think, in August of 2012. And so it's recent. It highlights all the gaps, and that's where the answer is. Thank you.
Great. We have another question. This is posed to Dr. Phillips. How might any increases in minority representation in nursing be used to more concretely address health disparities? Dr. Phillips?
Yes. Thank you so much for that question. And so when I talk about increasing the diversity in nursing, it's more than just saying we want to increase numbers. I think once we know that nurses from minority backgrounds are enrolled in our nursing programs, the undergraduate and certainly at the graduate degree level, it's important that when they finish their programs or even during their programs, that they are properly connected to those individuals and those stakeholders who are actively engaged in addressing health disparities. For example, we need to be linked with those individuals who are conducting research. If we're a graduate student, then perhaps that's a good time for us to immerse ourselves with being mentored by those individuals who are actually committed to conducting health disparities work. When we finish our programs of education, where are we working? Are we working with institutions and organizations that have an express mission aimed at eliminating health disparities? And so it's more than just about saying that we have an increased number of minority nurses, but I think establishing those linkages to other entities, organizations, institutions, individuals who are actively engaged and committed to addressing health disparities. And another important thing that I think that we want to remember is that we need minority representation at all levels, whether it's at the practice level, at the research level, and certainly at the policy level. I know from myself, with a little bit of beginning background in health policy, I've been working to get myself more immersed in the policy arena because, as you know, minority leadership in the policy arena is very important in terms of helping to shape national priorities and national policies. And so making sure that minority representation is there at all levels of practice, policy making, and that we are appropriately linked with those individuals who have a vested interest in addressing health disparities.
Thank you so much. It looks like we have another question here addressed to Dr. Williams. The Nursing in 3D Summit and Journal Supplement have been informative and a great resource for decreasing health disparities and improving health equity. What is next for the Nursing in 3D activities? Dr. Williams?
So what we've been doing, thanks for the question. What we've been doing is we convened the summit and we commissioned this public health report supplement in order to inform our potential applicant pools and our stakeholders that this is the direction that we're taking, that we're really shifting to this multi-level approach where we're looking beyond the individual attributes to all of the other social factors, social determinants that impact our students' ability to be successful in programs of nursing. So what's next for us is that we've already started to do this, is start to have this language penetrate into our FOAs, that we are having this agenda influence the way we make funding decisions. And so we will continue in this direction until we can see that there's some measurable impact in looking at more complexity in the factors that influence diversity and health disparities, as well as the ability to move towards health equity.
Great, thank you. The next question is posed to Dr. Phillips. How might we better document the contributions of minority nurses in our organization? Dr. Phillips?
I think we just have to start to do that. I think one interesting thought would be, I think organizations and entities such as HRSA, for example, or other organizations with a vested interest in health disparities should issue a call to help begin to collect some of these data. I think it's very important that when we are in our medical institutions or we are in our nursing organizations, that we include this in our strategic plan, that we are going to document the contributions of those nurses in our organizations. You know, if it's not in our plan, then we can't take the next step. And so I think we have to make a commitment to saying we really want to know what minority nurses are doing toward eliminating health disparities, figure out what are the appropriate measurement tools, and begin to figure out how this can be a part of our everyday business.
Thank you. The next question, I believe, should be posed to Dr. Williams. How can we address the misunderstanding or disconnect that occurs when workforce is mismatched with clients they are serving? For example, Middle Eastern providers serving an urban Hispanic community. Dr. Williams?
Yes, I think I answered that question with my previous answer, talking about the concordance between the provider and the populations that they serve. and that while we don't want to overburden our disadvantaged population into one sector, that all providers should have some shared responsibility for taking care of not only our racial and ethnic minority populations, but also those who are disadvantaged, but that there is some value and this data to show that when you have concordance, when you have populations that are being served by providers that reflect their demographics, that you see improvements in quality of care, and we are aware of that here at HRSA.
Great, thank you. The next question for Dr. Phillips: how can we best disseminate opportunities designed to enhance diversity in nursing practice, education, research, and policy? Dr. Phillips?
Well, first let me just say that we have seen a strong growth in the number of opportunities designed to enhance diversity. And I'm very pleased to say that the Robert Wood Johnson Foundation, Johnson & Johnson, HRSA, and many of our ethnic minority organizations have done a great job of trying to strengthen engagement in this area. I think in addition to advertising and promoting these opportunities in some of our professional journals, we might want to think about, are there some opportunities to partner with some of our consumer publications? There are some consumer publications that specifically target minority organizations, and so perhaps that might be a new opportunity for us to make sure that our younger individuals have an opportunity to know that there are indeed some opportunities for them to enhance diversity by becoming nurses. And our newspapers, our radio stations, and other ethnic targeted publications might be another way to go. I know that when we read our magazines, our publications like Minority Nurse and our other journals, they've been very good. We have Journal for Hispanic Nurses and other minority nursing organizations, but I think we might want to think about how can we capitalize on some of our consumer opportunities to promote these opportunities as well.
Great, thank you. I have a question posed just to the general panel. Anyone can chime in. It's a thought: can we use the term social exclusion when discussing health disparities?
I'm sorry, I couldn't hear the question.
Oh, certainly, I'll repeat it. It's a general thought posed to the panel. Can we use the term social exclusion when discussing health disparity?
Well, this is Paula Braveman, and I'll be happy to try to address that. I think we have to use it because it's really at the core that that health disparities are the health differences that adversely affect groups that have experienced social exclusion. It's kind of another term for discrimination, and I think it's a very useful one that's used more outside the U.S. than it has been in the U.S. But I think we can and should use it. We need to make explicit the fact that the commitment to reduce health disparities and the commitment to achieve health equity is about justice. We're not talking about just some sort of technical issue or epidemiologic comparisons. We're talking about placing a very, very heavy value on social justice.
Great. I have another question posed to Dr. Braveman. LGBT populations have been mentioned by Dr. Braveman and in the IOM report as being vulnerable and experiencing health disparities. How can those disparities be addressed?
Well, you know, there has been less information about health disparities adversely affecting LGBT populations. You know, that's not questions about sexual orientation and gender identity are not a standard part of a lot of the kinds of questionnaires that collect information for national surveys. So I think that there's a lot that we don't know about the health disparities. What we do know, though, very clearly, that this is a group that has certainly experienced profound discrimination, denial of a number of rights, including the right to marry, and that the experience of discrimination, the experience of social exclusion, is one that very likely damages health through physiologic pathways involved in stress, in responses to stress, and takes its toll through neuroendocrine and immune pathways, that wind up in a greater burden of chronic disease and premature mortality and adulthood. And so we know that those pathways are as likely to be relevant as reactions to stress experienced by LGBT populations as others. But we don't have the kind of information on that we have about socioeconomic disparities and racial or ethnic disparities.
Thank you so much. I think we're at the end of our Q&A time period allowed. Once again, if anyone is interested in seeking 1 credit for recertification and public health certification, the password is nurse, the number 3, and the letter D. Nurse 3D. And again, this webinar will be archived on the PHR website, as well as the slides for viewing later. And if you have any further questions, you can contact Public Health Reports, and we'll be happy to answer any of your questions. And I'd like to turn it over for closing to Dr. Williams. Dr. Williams?
Thank you. I want to thank everyone for joining us today. A special thank you to the speakers and their staff for their time and contributions to this very important public health topic. I also want to thank Erin Williams for managing this webinar from the Association of Schools of Programs of Public Health, and also to the Office of the Surgeon General for their continuous support. So please visit Public Health Reports website at publichealthreports.org to view the Nursing in 3D supplemental issue. Again, the credit, if you are interested in seeking 1 credit for certification in public health, continuing education, practice instruction, the password is nurse 3D. And this is the end of the Public Health Reports Meet the Author webinar. We want to thank you and have an excellent day.